physics, art, and math guide us down this path. Historical tales come alive, where science and stories dive. Blended facts with heart, knowledge from the start. Meet rich blues we sing, to the future memory. Health and science in the mix, Midridge got the fix. Complex subjects made
right
clear,
now
every episode
in ways that we actually acquire
Ramana
the
leads the way,
and ways that
explaining
make
day
me
by
more
day.
efficient.
In the world of digital streams, turning knowledge into dreams. Through the tales of old, new stories unfold.
Thank you so much for joining with me. It is truly an honor and a privilege.
MedBits Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges.
Hey, welcome to the MedBits Webcast. This is Ramana Namaraju. I'm the host. I just rushed from. I attended today a breakfast meeting from a Charles Drew Medical University in Los Angeles. There's a lot of dignitaries were there. It was a fun. They're talking about a lot of these equity and health equity and other things, and then how how the funding and all these things. They're all kind of concerned about it. Health is a very big challenging. Healthcare is a challenging in this country. We are going through. We need to solve this problem. Healthcare budget is really taking the economy down. If the healthcare is not solved, we can't solve any problems. So that's the reason healthcare is a problems has to be. That is our top priority to solve those problems in healthcare. That's why this podcast and other things. Where I want to attend and bring all facets. Diversity in thinking is important. That's what I feel. But let me tell you that I'm interviewing. Rush just landed just now from Los Angeles and back home, and rushed from the airport here to come back to meet our neck of my woods. She is from my home state, Srilekha Palle, Dr. Srilekha Palle. She is a doctorate in a doctor of physical therapy. So she has a extensive experience in rehabilitation side. We have to learn all of it from her. We have to listen to her. But let me better. She got the doctor of physical therapy from Boston University, and then what I know a little bit about physical therapy and rehabilitation itself. That is such an important thing. People productivity is directly connected with it, right? So if somebody is injured in the car, the accident or something, or you get a stroke, anybody to come back to the normal life, that is a rehabilitation is such an important factor. We need to really pay attention. Our parents, our relatives, they go through all these things. Either ourselves may go through one day. So we need to understand this process very well. Let me bring to the table Dr. Srilekha Palle from Virginia. She's the Washington, D.C. area. Let me welcome Dr. Palle. Welcome.
Ramana, thank you for having me. Thank you for exposing me to your audience. And I see the passion already from you. And I'm excited to be here. And I look forward to speaking to you and your audience.
Thank you. Explain to me a little bit more about your background and a little bit run down just briefly your background. And then we talk about a little bit about your rehabilitation side of it. First, run down a little bit about your background, if you don't mind.
Absolutely. I know, Ramana, a lot of people say, how did you get into healthcare? I say, I don't know anything but healthcare. I grew up wanting to be in healthcare. to be precisely. I wanted to be a medical doctor. That didn't pan out, but I ended up getting into physical therapy school, and I was quite happy being in physical therapy school. But then once I got out of PT school, came into United States when I was 22, got into Boston University to do my doctors in physical therapy, got into PT world, ended up just owning my own practice, learned administration, and just enjoyed being one of those administration. Got into George Washington University Hospital. Got into administration again in that as part of clinical coordination and so on and so forth. Went into corporate world a bit and then got into not-for-profit world. Just to put in a nutshell, as much as I enjoy clinical, I just realized I enjoyed administration part of it too. A lot of clinicians don't like administration. I felt like I was one of those special breed. I enjoyed both clinical aspects of it, but I also enjoyed administration part of it. So I ended up just sticking to the administration, but also having my little hands in clinicals. So I do a combo of both of it, and here I am honing in not only into physical therapy but also rehabilitation medicine. So I kind of manage physical therapy, occupational therapy, speech therapy, cardiac rehab, pulmonary rehab, just the entire gamut of rehabilitation medicine.
I'm glad you're one of those people who love healthcare and the administration. That's a bridge that definitely needed in this healthcare system. Let me ask you a question. Just you know, I am very ignorant of rehabilitation side of it. Very small, so you need to educate us, all of us. Let me. So one of the things, one area. Let us talk about the first workman. That the actual accidents and the workman's comp and the trauma rehabilitation, young people who are, that's, let us talk about them, then we can go into the stroke rehab and the cardiac rehab. Let us talk about the young people, that what is the process involved in that what is the actual process for somebody injured in the workplace, or somebody got accident in while driving. So what are the process involved in this kind of rehabilitation?
So the usual process is, I mean, if they end up having musculoskeletal injuries, there are two processes, right? There is one, again, I think that's the beauty of having both clinical and administrative part. I mean, the clinically, when a person gets injured, you have to heal clinically, but then you also have to go through administrative burden of insurance aspect, especially when it comes to workman's insurance. That's why I think, Ramana, your question is such a valid question, right? If you have regular insurance, you don't have to worry about the burden of proving to your employer that you are truly injured and you are actually healing, and you don't have to go through these re-evaluations. When you put in the word workman's comp, then a lot of limitations come into picture. You got to prove to your employer that you're truly injured. Then you have limitations of which doctors they send you to, and then you have to prove to the doctor that you really need these tests. Once you prove to the doctors that you really need these tests and you really need it to a certain extent, then you need to go through the therapy process. Once you go to the therapy process, you have to go through the grueling process of making sure you're meeting those outcomes, right? You got to prove to them visit after visit that you're improving functionally, right? So there is a series. That's why I said trauma is one thing, getting injury is one thing, healing is one thing, but making sure you're making functional progress visit after visit is also important in order to make sure your visits are all approved. So I think clinically, mentally, and improving is quite important when it comes to workman's comp. It's
The,
completely a different gamut.
the reason I'm smiling is that the employers always want the employee back to the work, and then employee says that no, I'm not cured. There is a friction there always. I see that all the times. That friction maybe is not, so you're the decision maker there. You are the people who tell us really that what goes on. Somebody
Yeah.
back pain is one of the common complaints among all the people, and then we used to today test that really back pain is valid or not, but I don't know much about it. So how
Yeah.
do you validate these people? Real, these are pain is a subjective thing, right? So pay. How do you validate this? Really, this guy is going through, is incapable of going to the work. That is a, the employer wants him back, right? There's a
Correct.
friction there. So how do you, where do you stand in that, how do you address that part?
So, Ramana, we go through a series of tests, right? I mean, that is the beauty. That is where our subject matter expertise comes into pictures. We have a series of objective tests. If you have a cervical issues, you have lumbar issues, you have spinal stenosis, you have traumatic brain injury, you have cognitive issues. We have series of battery of tests that we go through. They're very objective. We definitely take subjective complaints into consideration, no doubt about that. We call it as soap notes, right? Subjectivity, objectivity, our assessments, and then we create a plan of care. Finally, based on that subjective, objective measurements and our assessments, we create a plan of care for the patient. So it's just called as soap notes. After finishing the battery of tests, there is definitely what is called as malignancy, right? There is always we are able to detect. That's where our subject matter experts comes into picture. But then at this point, I also would like to always introduce the concept called as work conditioning. The physical therapists and occupational therapists are experts at work conditioning, because we first try to first reduce the pain. Again, series of tests, objective tests. We localize the pain. We reduce the pain because pain is the factor. Then we try to stabilize the muscles, and then we strengthen the muscles. And then after that, we tend to do the conditioning of the work, because we want to ensure that they're conditioning their muscles before they go to work. And then we try to do a lot of simulation activities, because every work is different. Let's say you're a computer professional, so you have to do prolonged sitting, I'm sorry. If you are working in the Ford factory, your work style is completely going to be different. That is where that occupational health comes into picture,
Yeah.
occupational medicine comes into picture. So we transfer them actually from regular traditional physical therapy to functional medicine, or we transfer them to work conditioning program. We transfer them to that work strengthening program. So physical therapy is like this broad scope of therapy, where we start from acute injury, pain functional therapy, to this work conditioning program. So we
That's
take
it.
them through the entire series.
Let me ask you. So functional medicine is a functional thing. Who is watching the functional side? You're the same people watching it, or the same. Just the process is different, but you're the same people watching it, and you're trained to watch them and do the process, right? Or you need a.
Some therapists, yeah, some therapists are trained, some therapists are not. Like if you're talking to me, I'm not at all trained in work conditioning programs,
Okay.
whereas some therapists are very trained in doing work conditioning therapists.
Yeah, tell,
So
tell us a
you're
little bit about work conditioning. What is just
yeah.
explain us a little bit about work
Yeah,
conditioning is.
we call them as industrial rehab therapists, right? Like it requires additional training. Ergonomic therapists, home modification therapists, that requires additional certification. Work conditioning therapists, so you have to go through either some weekend courses or certification courses, and then the setting is also very different. So traditional orthopedic sports medicine therapists won't be able to actually train those places. So if you're going
Uh,
into yeah, go ahead.
yeah, you're mentioning the professional side. What about the patient side? What that work conditioning means for the patient perspective?
Basically, work conditioning means you go through the entire evaluation to understand what your work is. Let's say if you're an industrial, if you're a Ford employee, we sit down and do the entire evaluation to say, talk to us. What's your work like? Are you lifting 50 pounds? Or are you lifting 150 pounds? So what can we do to simulate these activities? If you're going to be doing prolonged sitting, is it 4 hours of sitting? If so, are we able to simulate? I mean, we can simulate 4 hours of sitting, but what can we do to as a compensatory mechanism? Are you able to modify your work in such a way that you can actually have a desk where you can actually stand up and do the work? Because right now you can do so much of ergonomic. That's where therapists come into picture, because in our own workplace we go to like radiology settings and kind of modify their workplace so they're not kind of getting injured doing repetitive activities. So that is exactly where physical therapist expertise come into picture.
Dr. Palle, I'm in Silicon Valley. most of the people are computer programmers. So they're all from our state. You and me belong to the same state. A lot of programmers are from our states, in the southern states. So one of the common complaints, the carpal tunnel syndrome. That's a
Yes.
way typing. Another was ergonomics. See, that's what he said. That chair, the way the pose, the threat is that the way that we sit down, and one of the things is symmetrical aspect of the sitting down there and standing up and all those things. What do you suggest to these people that complain? It's a very serious problem here, because the people stay in front of the computer, including me, hours and hours, and then there is some problem with the carpal tunnel syndrome. That is real or not? A lot of things are going on there. How do you address that kind of problem, and what are the rehabilitation process for that?
Oh, it is a real problem. It is absolutely a real problem. Musculoskeletal problems are real problem. Cervical strains are real problem. Carpal tunnel problems are real problem. A seated posture. I mean, it need not be even software engineers. Even as simple as kids as young as middle school kids actually come to rehabilitation for musculoskeletal
Mm.
injuries. Right? Postural symptoms are real issues. I always say even kids develop what is called as postural. I mean, all the muscles, kind of ligaments, kind of get really tightened up and stuff like that. So the best is, I always say, have a standing desk and make sure you are
Wow.
standing up every 30 minutes, and make sure you're getting your desk analyzed by an ergonomic specialist. I mean, doing little things as having making sure you're having a exercise ball next to you, so
Mm.
you're exercising your muscles, or you're having a little. I know I do ergonomic analysis for my own husband because he has like two other monitors, so he's constantly
I
moving
have the
his
same
neck
problem.
there
Yeah.
to him, right? Having a cushion underneath your seated buttocks, so you're ensuring that your hips and knees are you're aligned, your wrists are aligned with your shoulders, so you're maintaining that 90-degree angle at all times, and getting as frequently as you can. I know it sounds very simple, but making sure you're getting up, or making sure you're seated on a ball versus actually a regular chair, because as long as you're getting that sensation or proprioception, feeling that you have to actually get up, or it is actually giving a sensation that you have to be seated at 90-degree angle, you're making effort and you're activating your core muscles. Because if you're always seated comfortably, that you have a very good chance that you want to slouch, right? So you have to be able to feel like your core muscles have to be activated and you're making an effort to sit up, because if you're too comfortable, then you slouch, if that makes sense. Otherwise, musculoskeletal injuries and back injuries are 30% of what physical therapists see on a daily basis. And if you're actually going back to looking at the stats, millions of dollars are spent on just musculoskeletal injuries
Particularly
issue.
back pain, right? Back pain is one of the.
Particularly back pain. Particularly back pain. Yeah.
So that is one of the things that I deal with. That I have a good friends. Some of the friends are basketball players. They have this symmetry. They teach them dances and all these things, so they can do the less prone to injuries if the way they move. That's why they do ballet dancing and all those things. I think that is something that is interesting. What I thought that is the way you move, you sit down, and everything is really helps that process. Is just a very important. The posturing is the particularly if you're a software engineer, particularly in Silicon Valley, we sit down in front of the computers like hours and hours and hours. So you're saying that if I understand you correctly, that you say at least 30 minutes you get up, and then you say take a small ball, so you have a cushion inside. That kind of things. Small things will help. There's no question about it. So let us
Absolutely.
talk about the serious part of things a little bit. Let us talk about stroke and trauma, and let us talk about the stroke side of it. Because is the biggest one of the problem is that is a second probably biggest the life-threatening incidents. So what people come out of the stroke is very challenging, right? That's a pay the loved ones and people around them, and it affects the entire family itself. So what is the process involved in the stroke rehabilitation process?
Yeah. So, Raman, I think one of the things that I always tell caregivers is be the best advocate for your family members. 90% of stroke recovery happens in the first 90 days.
Really?
So, you have to advocate for your families while your family encounters the stroke. The recovery starts within the first 24 hours, right? Once the
Really?
TPA is given, the acuity happens, the rehab has to happen in the hospital. So if you see that a physical therapist or occupational therapist or speech therapist does not come in within 24 hours, you got to ask for it. And then the rehab starts within 24 hours. In our own hospital, I ensure that a PT and OT and a speech pathologist sees the patient before the patient gets discharged. And at least one of them goes and sees the patients within 12 hours or 24 hours, right? And if the loved one has deficits, make sure they go to acute rehabilitation. What happens in acute rehabilitation is they are bound to get 3 hours of therapy, and that's where the majority of the recovery happens. Let's say if there is not great of an advocacy and patient is doing fine, and fine as in like, okay, patient is walking fine, and they send the patient home, you're neglecting the fact that patient doesn't have the cognitive skills that they need, and cognitive skills often gets neglected. Let's say if I end up having stroke, but I just come out of the stroke acute symptoms and I'm just able to talk, and then the doctor feels like, okay, Srilekha is able to talk, so let's send her home. But what the doctor might have missed is Srilekha was able to work very well. She was able to have an interview, has all these executive skills. She was an active dancer, and so on and so forth. And then I come home, and then I'm sleeping a lot. I'm not interacting with my friends as much. I don't have fun. And they just think that I'm just a little depressed because I just had a stroke and I'm just not feeling myself. And then the days pass by, only to realize that I just never recovered at all, right? So it's hard when you come back from home when you don't have the trained medical professionals. So I think the best thing that you can do is advocate, 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 because executive cognitive skills, those comprehension, expressive, receptive skills, and occupational therapy, which will get you back to regular activities of daily living, not just physical therapy, because it's easy to realize when a patient doesn't walk that you need physical therapy. But I emphasize on this executive comprehension skills through occupational therapy and speech therapy to never let it go and advocate. Once you receive this acute care, acute rehab outpatient, you will recover close to 95%. When you miss that in the first 90 days, you'll never be the same.
Dr. Palle, a lot of we are all in Silicon Valley, and then a lot of them Indians, we're all over the world. So their parents are at home, back home in India. What kind of so they go through sometimes stroke, some of the family members. What do you suggest in countries like India that rehabilitation is not? What is the status of the state of the affairs in the rehabilitation side in India and the other countries, particularly India? You can tell us a little bit about that, because a lot of people are concerned about their parents at back home. So what is the state of that, if you know anything about that Indian situation, the
I
rehabilitation?
actually do know. In fact, believe it or not, 8 years back when I went to India, there was a delegation with Ivanka Trump. And I was part of the delegation where I pitched into Apollo Hospital a stronger acute rehab transitional setup. There's a strong acute care setup, there's a strong home care setup, but there's the transitional period was missing. And I proposed that, and they started kind of working on it. So, but I still think that strong acute rehab setup is missing in India. That ecosystem is missing. I think they've gotten so much better in the past 8-10 years. I still believe that there is definitely room for that. This is exactly what I would say. They have to find a residential where mom and dad can be left for 3-4 hours of therapy each day. Mom and dad should not be taken home and be left for untrained professionals who will do 30 minutes or an hour of therapy, because that is not at all enough. Whenever I go to back home, I see a family that is very close to me, where the family member received therapy here, has gone back, now is more spastic. But the therapy is given more and is receiving acupuncture and so on and so forth, but the patient is not the same, is more spastic, because the patient is missing all the key factors with neuro rehabilitation that the patient was receiving here. So getting into outpatient rehabilitation centers, getting into that acute rehab is super crucial, not
Yeah.
home therapy. Home therapy does not cut it for stroke rehab.
Very, very good advice. So you have to be vigilant in the sense that you have to be very participant when you are worrying about your parents or somebody in the loved ones back home. So let us move into the cardiac rehab a little bit. So cardiac rehab is a very common. Everybody has a cardiac strokes in this country. Cardiac disease is a pervading disease in this country. You know, we are all ended up in the cardiac problems. So a lot of times congestive heart failure sometimes happens in a lot of cases, that is. So they put in the rehab side, and those kind of things. What do you do? What do you offer in the cardiac rehab side? Actually, a lot of times doctors say go to the gym, exercise, do it without unsupervised. Just I think gym and the regular gyms can do the job. So tell us a little bit. Is that really can replace the professional training, professional rehabilitation process?
Yeah, Raman, I'm very very glad that you asked this question, because Million Hearts Initiative is one of those initiatives that is coming from CDC. They have said that very little, as little as 20% eligible cardiac rehab patients indeed receive cardiac rehab, because cardiologists have not been referring patients to cardiac rehab, and that is very unfortunate, right? What cardiac rehab is? It's 12 to 14 weeks of structured cardiac rehab program, and people that receive cardiac rehab have less than 2% chances of getting readmitted to the hospital, and have less than 2% chances of reoccurrence of cardiac attack again. So think about the chances of them getting another episode of cardiac. That itself should be a good reason why cardiologists and physicians have to give.
Yeah.
So that in that structured program, they receive nutritional assessment, because one of the reason people have cardiac is
That is
because of
good.
poor nutritional issues. So they get this nutritional consult. It's a structured exercise program. Throughout the exercise program, as long as the patient needs it, they get monitored. We have what is called as telemonitoring, where they're using ECG. We kind of monitor their heart strips to ensure that actually their heart strips are working well. And I'll give you one incident. One of the patient told me saying that they come for wellness program, which is actually a phase 3 program once they're discharged from 12 to 14 weeks. And I asked them why the person on his 100th birthday, he celebrated his 100th birthday with us in the gym
Okay.
area. And the person has been coming to us for 30 years. I said, what is the secret sauce? He said, coming to the cardiac rehab program. I said, what makes you want to pay us for all this time? Because that's a self-pay program. He's like, I realize the value of your program when I see somebody having an MSET in this gym, and your nurses are resuscitating this patient. So that is the value of cardiac rehab program, right? Because we go through and then we slowly take them away from those monitors. We gradually progress them. We start them off with a monitor. We kind of ensure that we are monitoring them unless we don't need to monitor them as their heart starts getting stronger. We give them the confidence to go out and think, so unless their muscles get stronger. So we progress them until they reach their prior level of functionality. So it's a education, it's a confidence, it's muscles getting stronger. That's a structured 12 to 14 weeks program. Very, very valuable program. And also think about the psychosocial aspect, right? Sometimes you really need that boost in your thing, that no, you can do this. I know you had this life-changing incident. You can actually do this and get back to your life, because people are afraid to touch things. They're afraid to twist their body, because now they're afraid that they're going to have another attack. That's not a way of living life, right? You want to give them the confidence that they can actually indeed have a quality of life after heart attack.
Yeah. So yeah, that is a major. Yeah, I'm glad you told that. We need a professional help. It's not just the doctors need to really participate in this area. A lot of them are thinking about it, and then then reevaluating this heart rehabilitation. The other one is a pulmonary rehabilitation. Tell us a little bit. I don't know much about it. So kind of COPD, and there's a common problem. I think that's the people that they need. So tell us a pulmonary rehabilitation a little bit about that, very
So if you
briefly.
think, yeah, oh, absolutely. Pulmonary rehabilitation or SETPAD, which is another program that we do. Pulmonary rehabilitation, as you know, it's more of it's a degenerative diseases. We can't reverse the disease, but we can definitely maintain the disease. Usually, Medicare and all of those give us like 72 visits per lifetime, right? So we kind of conserve the program, conserve the visits in such a way that we don't use up because we want to make sure we save it for their lifetime. So what when patients come to us, we ensure that we monitor their oxygen levels to such an extent that we are talking about their lifestyle management. We teach them how to breathe. We teach them a lot of diaphragmatic breathing to ensure that they're able to breathe and conserve the energy and still be able to exercise within the oxygen capacity that they have. We teach them how to monitor their own oxygen levels and still be able to exercise. Again, we do a lot of dietary consult and so on and so forth. So it's more of like lifestyle management. We see them for like 9 to 12 visits or sometimes more if they need. We talk about their smoking cessation if that is one of their lifestyle. We also give them PHQ-9. As you know, it's one of those depression scores to see what their depression scale is. So again, we measure their lung capacity, oxygen capacity, and that's one of our way of trying to see if we can make improvements with exercise program. We give exercise prescription, and we ensure that we talk to them if they're attending their gym to make sure if we can adapt any of our exercise program, that they can actually do it in the gym so they don't have to come to us, because at the end of the day our program is a lifestyle management, because the goal is that they don't have to come to us forever, so they can just go back to their gyms and adapt our program to the gym.
Okay, so when I come back, I will ask you. Thank you for educating us. When I come back, I'm going to present a topic on one of the professor from Dartmouth College, and I tell you about that. And then after that, I come back and ask you questions about your what do you think of the online, the remote physical therapy aspect, and then what do you do, and what kind of consulting work you do, and how do you what are the things particularly specific about your consulting side. We can talk about it. Let me talk about a little bit about my physics people a little bit. I want to bring them in the medicine side. See, her name is Donna Meadows. She's the professor of Dartmouth College. And then what she did was, so you and me when watch together, you can jump in anytime, Srilekha. Let me I want to tell you, what she did was in 1990, before that actually, she gave a report, uh, 1,000 people in the village, what would be the combination of those people are. So she did a beautiful, then there's 100 people project is called. I'm going to play that a little bit, if you don't mind. I'm going to play that video. Um, so just watch that video.
100 People Foundation is asking 500 schools from 100 countries to nominate 10,000 people to help us find the 100 people that best represent our world population. We've created a lesson plan that explains how a student can nominate someone they admire from their local community and fill out a community profile that helps us understand where they come from.
This is my schoolhouse. Masaya ako na in-interview ako, na camera ako. Masaya ako na nakilala ako nila, ma'am, natulungan nila ako. Masaya ako. Lalo na sila, masaya ako. Kasi as in, di ko sa dekalain na ganito, interview na ako, may camera ako. Kasi sa amin, wala.
We are asking the children of the world to introduce us to the people of the world.
I think this project will really open the eyes of a lot of people that we're not alone in this world. That it'll be good to see how everyone else lives in the other side of the world.
Irsiba kala dori dumduma din imirga bora kulmete mefo imdu doro din kaban bora imfai bora kulu imete mefo imfai di yanja asibo.
So that is a 100 people project. Actually, is inspired by a professor of Dartmouth College, Donna Meadows. I tell you about her a little bit very quickly. Then after that, she is actually born in 1941 in Chicago, PhD in biophysics from Harvard University. She is a MacArthur Fellow. 1941 woman going to the physics Harvard. Think about it. So Sri Palle is also doctorate. She was the first one as a modeling MIT magnetics. She helped actually magnetic storage that you see now. There's a lot of magnetic storages that you see. She is one of the inventors of that one. System dynamics. She's a very famous for system dynamics. This is one of the things. She wrote a lot of books. So what she did was she with her husband 1 year she traveled across the Asia, India, Afghanistan, Pakistan, Iran, Turkey, Sri Lanka in a car, ambassador car. She went through entire this country. They traveled around in 1960s and 50s and 60s. She traveled around this India and entire world. She really came up with she's MIT professor, and then she is already then she went on to it's a Dartmouth College. Professor of 29 years in Donna Meadows is in Dartmouth College. She ended up in Dartmouth College. She wrote a book. It's called Thinking in Systems. It is 500,000 sold. Thinking in Systems is system dynamics. All the interplay between all the policymakers, the processes and everything, the health, all of them are how they interplay this whole thing, the growth of the expansion of the population itself. So she wrote these books are at that time 1960s. Her books were written by every educator was reading, every professor was reading her books. 29 languages, they translated into 29 different languages in the world, her books. So she's an unsung hero. A lot of people don't know about. She was a Donna Meadows. Is a lot of these things she talked about. Interconnectedness. That is like patients and doctors, finance, insurance. All the interconnectedness is a system engineering. She created a mathematical system engineering that how do you connect all of them together? You put the mathematics behind it. That's what she did. So patients, doctors, finance, and insurance, there is some kind of a system engineering is behind the scenes. Stocks and flows that they talk about ER, patient flow, admissions and discharges, how that flow works. She gave a excellent the processes for that, feedback loops. That a lot of times this EMR, biggest failure of EMR is there's no feedback. They don't take, it's a one-way street. You follow that up. That's one of the reason doctors did not crazy about EMRs, because that's one of the things he did not take the feedback loops. That's one of the things Donna Meadows was suggested that feedback loop is a very important leverage points. She talk about What is the maximum leverage? Certain things, preventive care is a maximum benefits than sick care. That's what the holistic approach. That is a thinking in systems. That's book. Donna Meadows wrote in 1960s and 70s. She's an amazing woman. Leverage points. I leverage points, and as I told you, right, disease to prevention is a prevention to sick care. That mid-level, the transparency is important. Mid leverage points, the transparency is a, so she gave all the engineering points. She was a physicist. Low leverage points, building resource buffers. Those are all, which is the highest leverage point you got to do. That is a prevention is a much better than so Donna Meadows did uh, she was concerned about exponential growth. A lot of people don't understand exponential growth, the effect on the planet itself. Aging population, the India, China, United States. India is not, but United States, China, Japan, all of them are getting older. Only Africa and India still young population. Finite resources. The resources are finite, that she says. Healthcare budgets and staffing. These are all. So she is giving a writing in all these books. Overshoot and collapse. She gave a very systemic process for all these healthcare problems. She wrote in an engineering way. She wrote all the sustainability, and then one of the things is she wrote in Cuba. The access to 1,000 population. She gave Cuba as the highest number of access. That can you believe that? Not the United States, 8.4. They have a doctors for 1,000 people. USA is number 2.6, long way down. In the Monaco has a 7.5. India is a 0.9. Is all the way bad. The worst country is Niger, has just a 0.02.2. Nurses. Finland has an excellent situation of Finland. USA is 17. It's not bad, USA, but India is still bad up there. Yeah, that's So she gave the access to maternal mortality rate for 1,000. Finland is 3. United States, one of the highest mortality rates in the United States, 32.9. India is 103. It's just way above. South Sudan is at 1,200. For 100,000 people, 1,200 people die. Shortage of 1.1 million midwives we need in the that's this is a matter. This is a Donna Meadows gave inspired all these mathematics and statistics. Infant mortality, for example, 100,000. Morocco is 1.5. United States is 560, very high. It's such an advanced country. India is a way above. It's just horrible. 2,769. Sierra Leone is the worst country. That is really the highest infant mortality there in the Sierra Leone. So mammograms, for example, mammogram access to 1 million. Italy has one of the highest access. United States is not bad. United States, India is a very low. Uh, Radiation therapy centers, for example, PET CT scans and all those things I used to sell. United States is 12.4. India has a 0.4. Cancer treatment in India is a dismal. Africa is less than India. So we're all in a really bad shape in the cancer treatment side. So cellular, one good thing, the positive thing about all of this thing, 65 out of 100 people, 65 would be cell phone users. 47 would be active internet users. 95 live in area with the mobile cellular network. So 95% of the people have a mobile cellular network. That's a very good thing happened. That's a very positive thing you say. Cell phones became a very positive. In fact, it became a very. So quality measures are in the United States. They do inpatient. How many inpatients are in the hospital side, prevention, patient safety, and pediatric care. These are the quality measures in the United States. These are the 4 points they do. But in the World Health Organization, do different way a little bit. They do effective, safe, people-centered, timely, efficient, integrated. All this 8 million die for the poor quality performance. Just the quality measures. Lack of quality measures kill 8 million people. that's a lot of people. Because so cost measures is support cost and patient cost resources. All these things important. Cost measures are support cost of resources. These both of them are combine them together. So these are the things we do, literally, that what we do. Countries with the oldest population in the world. You want to know what? Japan is the oldest population. Italy, Germany, and China, all of them are getting older. You know, the youngest population, you want to know? Countries with the youngest population, all African countries. Niger, Mali, Uganda, all of them are, not even India. So one day we may have to depend on them. System Dynamic Society. So Donna Meadows started a health policy special interest group. It's called System Dynamic Society. So there's a lot of these people give all these kind of statistics, and they give the right direction for all the people. Healthcare policies is not just we solve the problem. We need everybody's help to solve this major problem of healthcare system. So this is Donna Meadows. She died in a very young age, actually 2001, bacterial meningitis. She died with the bacterial. Donna Meadows, an inspiring environmentalist, scholar, writer, and a teacher. She's one of the Donella Meadows project. If you wanted to see, you want to know about her, you can go to donellameadows.org. Is an amazing woman. We need a woman like that, and a Sri Palle, and we need a more woman like that to come down. Thank you for watching, and let me bring Sri Palle back to back to the stage. Yeah,
Yeah.
welcome. You see that that we need a people. How much help is required in this healthcare complex structure we have. Yeah,
Yeah,
go
very
ahead.
inspiring, super inspiring. And those stats are oh, wow. Thanks for
Yeah.
putting together such great stats. Sometimes numbers tell a story.
Number has a story. So
Yeah.
that's what is the number woman, that. So that is very important for all of us to solve these problems. Just health is a global problem, because diseases. With the COVID-19, we learned there's no passports required for the diseases. So that is a bigger problem. We need to prevent all those kind of things. Let me ask you now. The second question is the biggest question for you, is a little bit about the physical therapy online. Everybody is talking about a little bit. Everybody get excited. What is your take on the physical therapy online?
Yeah, I mean, just like anybody else, I said rehab medicine has also gone virtual, right? I think we were doing remote therapy just a bit before COVID, and during COVID we did do quite a bit, and even now we do hybrid. I think during COVID, especially in pediatric world, in school system, speech therapists were doing quite a bit of speech therapy online with children, which was actually quite successful. And when it comes to physical therapy, we use a lot of AI technology, right?
That's what I
And
was.
yeah,
Good. I'm glad.
and for certain aspect, if you think about it, monitoring patient exercises using AI technology to ensure that home exercise programs, the patients are adhering to home exercise program, is a good thing, because patients don't have to come in and spend 15 minutes trying to tell us whether they did exercises or they did not do exercises. They are showing us the same home exercise program, and then us correcting and showing them is very repetitive and redundant, right? So if they're able to do that, and there is a software using AI technology where before they come in, the therapists are able to, during their downtime, they're able to actually see it. That's a good improvement. It's a good use of our downtime. We are not wasting patients' time. That's a good use of AI technology, and some of the clinics have adapted that very successfully, and some of the insurances are actually paying for it. So if there is a cancellation, some of the therapists are actually asking patients to record when they're home, when they're doing the home exercise program. We use it as wearing technology. Use this as a technology when you're doing your exercises, so it records for us. It tells us whether you're doing it right or not. We will provide the feedback, and then you get the feedback if you're not doing right. So when you come here, you're not wasting time. We get paid for that, and you are not wasting time when you come in, and you already get the feedback live. So next time when you come in, you already have the feedback. So, and that's one technology that has really helped us. There are tools for that. We also have what is called as dictation technology, like how physicians are doing, right? That has really fastened our technology and the redundant documentation, because now the technology like Dragon is already able to note down. We have smart phrases. We use tons of smart phrases, right? So the repetitive things that we are documenting over and over again, the technology already recognizes my voice. So the minute I say it, it kind of goes on and documents for me, and then all I have to do is make some modifications. So we are already, and then that is from documentation perspective, but from actually using it on patients, we use what is called as gait analysis. We use what is called as exoskeletons. We use stem cell therapy. I mean, physical medicine, and the reason I don't use physical therapy is because rehab medicine is like OT, speech, cognitive therapy, and it's a lot more than just physical therapy, neuro rehabilitation, and all of that, right? So we are starting to use technology like there is no other day in the rehabilitation medicine section.
I think, as you said, that the AI is going to play a major role in the gait analysis, particularly Parkinson disease detection and all those new kind of detection. Slurring speech. Somebody said that handwriting itself, they can detect a lot of diseases. So there's all these AI can play a role. By listening to the talk, and they can say that gait analysis and speech therapy and speech recognition, all those things in the AI can play a role in the future about the diagnosis and all those things. I think you're absolutely right. And then one area you said online is the children. We are all a lot of immigrant children. They have the accents, and then one of the things you can do much easier way to is instead of 3 hours, take it away from their friends, and then put in a separate room. Instead, they can do from home these exercises, online exercise. That's a very good, helpful. That is a very helpful to the particular immigrant children. Do you agree?
Oh, absolutely. I mean, accent training is done by a speech pathologist all the time. So that's another benefit of it. I mean, going back to Parkinson's, we have what is called as Lee Silverman big therapy and voice therapy, right? One of the thing that has been recent revolution is even the walker, because one of the big principles is we have to ask our patients with Parkinson's to walk big, right? Because in their mind, because of the neurocognitive issues, neurodiversity issues, they think they're taking steps large enough, but they're taking small cadence steps. So what this walker does is it shows in a laser format. It projects the laser, so it actually prompts them to put their cadence near that laser. So instead of us telling them, saying that put your feet over and over again, repetitive things, which can annoy patients, right? We're constantly like, Mr. Smith, put your feet forward, make it big, make it big. The walker is actually prompting them because it actually signs you. So those are some of them. Then they can also carry it forward at home, because at home there is no Dr. Palle, there is no Shri telling them. So this is a good takeover. So these kind of technologies are widely used. Like I was just telling, in cardiac rehab, we have now home electronic monitors, right? In fact, there is an Indian female. One of my friend has Nimble Heart. It's a home monitor that you can just dispense it home, and you can use that as a home technology once you get discharged from cardiac rehab, or if you can't afford to come to cardiac rehab, you can use that as a remote monitoring for yourself for rural healthcare, because not everybody from rural, if you're living 40 miles from the hospital and you don't have access to come to cardiac rehab, you can use this remote technology as well. So there are a lot of things that are coming, which is quite exciting and innovative.
Yeah, it's very. I'm very impressed. You educated quite a bit to us. The other thing I wanted to ask you is, what is your, what do you do? Your business side of it a little bit. You do a consulting work, and what kind of consulting you do?
Yeah,
And
I
what,
mean,
because
I always say, I am very passionate about rehab. I always say mobility is medicine. Physicians focus on two things that I preach on a daily basis is that just like the way you give vitals and give pills, but if patient can't eat and walk, nothing matters. I said you can't walk, nothing matters in life. I've seen that personal experience in my own family. I mean, you can get up and walk, nothing matters in life. I may as well die, right?
Yeah.
So mobility is medicine for me. So as much as your blood pressure needs to be stable, you also need to eat and walk, right, in order for you to have good mental condition. So truly believe that mobility is medicine, and I preach that to everyone. As I'm managing clinically and administratively, operationally, and strategically, I also do a lot of consulting. When I'm doing consulting, I write a lot of articles on price transparency. I believe in quality of healthcare, right? So I do.
So your website is srilekhapalle.com, eh?
Yeah,
Your name itself,
correct.
srilekhapalle.com. You can get a lot of information from you. So
Yeah.
yeah, that's very good. So yeah, mobility as a medicine. I like that. I love that. Is actually one of the biggest shift in the biology itself. The when start moving things, the biology started moving. That really changed the life cycle of the system. So we became, as a humans, the next stage of the life evolution happened after the mobility. So you correctly put together mobility as a medicine is absolutely right way of saying it. Thank you so much, Dr. Palle. You're an honor to have you. You educated a lot of us. Just I'm very ignorant of this physical with the rehab medicine, but you gave us a lot of education to us. Thank you so much. You want to say a final word here? You go ahead and say the final words for you.
No, Ramana, thank you for doing this. I always say that there are not many podcasts that kind of focus on bringing in all facets of medicine. So, especially not as much in physical medicine. So, I totally appreciate the opportunity for talking to you and your audience. Very much appreciate the presence of having someone from rehab medicine talk to your audience. Thank you again.
Particularly, yeah, it's a special honor for me that you're from the neck of my woods. So thank you so much. We are from the same state, and we go through the same kind of a process. Thank you so much. Thank you for joining. Good night, all of you. Good night.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it